I'm now going to talk about the dietetic treatment of patients with liver disease. So first of all, looking at patients with liver cirrhosis. So we recommend patients have what we call a cirrhotic eating pattern. And this is carbohydrate containing food and drink every 2 to 3 hours and at least 3 to 4 portions of protein a day. So to translate that to patients is to try and have a protein source with every meal, include protein with as many snacks as possible, and have protein-rich drinks throughout the day. The cirrhotic eating pattern also includes a 50-gram carbohydrate bedtime snack. So these images are demonstrating what 50 grams of carbohydrate looks like. So 2 slices of toast with jam and fruit juice would be 50 grams. Porridge with a good portion of jam on top would be 50 grams. A hot chocolate with a muffin, 5 digestive biscuits, a 40 juice, bowl of cereal with milk and a banana, a rice pudding pot with 3 digestive biscuits, and a sandwich with a glass of milk. So each of these snacks contains 50 grams of carbohydrate. Patients with early satiety or poor appetite might find carbohydrate dense options more manageable. So this means more sugary options. And ideally, they should include a source of protein at bedtime too. This is going to be the best option for them in terms of preventing muscle loss. If patients have diabetes, then we need to recommend more starchy snacks. So things like a bowl of cereal with a piece of fruit, or porridge with a piece of fruit, rather than very high sugar snacks like 40 juice, jam on toast with fruit juice, and we need to be monitoring their blood glucose. So this is results from a study that compared the effect of a nighttime to a daytime nutritional supplement over 12 months on the total body protein of patients with cirrhosis. So one group, they gave 2 Ensure Plus a day and they told them to drink them between 9 AM and 7 PM. The second group, they gave 2 Ensure Plus a day and they told them to drink them between 7 PM and 9 AM. So this chart, the first chart in the middle of the screen, is showing total body protein changes at 3 months, 6 months and 12 months from baseline. And you can see that the group that had the daytime Ensure Plus, which is the white bar, they did have improvement in their muscle or their total body protein, but that improvement was much less than the group who had the nighttime Ensure Plus, which is in the black chart, and the nighttime Ensure Plus had a significantly better improvement in total body protein than the daytime Ensure Plus. And then the chart on the right is breaking it down by liver disease severity. So the one at the top is Child-Pugh A, which is compensated liver disease, and then Child-Pugh B and C is decompensated, with C the worst severity of liver disease. And you can see by the different grades of liver disease, the total body protein change was much better for the nighttime one across these different types of grades of liver disease or severity of liver disease. And this systematic review is reporting the effect of a late evening snack on improving substrate utilisation, so using carbohydrate rather than fat or muscle, and nutritional indices including skeletal muscle mass and clinical outcome on cirrhosis. And their conclusions were that with a late evening snack, so a bedtime snack, the change in substrate utilisation from glucose, so carbohydrate, to fat is delayed, and long-term late evening snack increased lean muscle mass. They found that the snack could be food or supplement drinks, so you can take a food first approach if that's appropriate for your patient, and that The late evening snack is also really valuable in early liver disease, so compensated cirrhosis, your child Pu A, because it helps to preserve existing skeletal muscle. So we shouldn't be waiting until our patients are decompensated to get them to have that bedtime snack. Even with compensated cirrhosis, we should be recommending that to stop them from becoming sarcopenic. These are two forest plots from a different systematic review looking at a late evening snack, and they looked at the type of fuel that was used for metabolism after a bedtime snack. And they found that in this top forest plot, that more energy from carbohydrate was used with a late evening snack, and the bottom plot is showing that the energy coming from fat metabolism was lower in people who had a bedtime snack. So this is showing that they're using the carbohydrate from the snack and preserving their fat stores, so not losing weight if they have a bedtime snack. And the results suggest that the catabolic state of cirrhosis can be improved if patients have a late evening snack, so we can stop them from losing weight and losing muscle if they have this late evening snack. So as well as thinking about cirrhosis, you need to think about if your patient has malnutrition. And if they have malnutrition as well as liver cirrhosis or without liver cirrhosis, then they need to be having high energy food and drink. They need to be following a little and often approach to be able to meet their increased energy and protein requirements to treat that malnutrition. And they need to add extra to the small portions that they're managing, so food fortification and lots of extra nourishing drinks as well. So as well as thinking about the eating pattern for cirrhosis, you need to, on top of that, be thinking about treatment of malnutrition, whether they have cirrhosis or don't have cirrhosis. So there's different methods of nutrition support for our patients with liver disease. Food and getting, the nutrition that they need from regular food intake, meals and snacks is important. Oral nutritional supplements between meals, after meals, before bed is also helpful. Sometimes patients need nasogastric feeding, but if they have delayed gastric emptying because of ascites or their other liver disease symptoms, they may need nasojejunal feeding. And it might be that some of our patients, we want to go straight in with NJ feeding because we know that they experience a lot of nausea or they're experiencing vomiting with oral intake. Gastrostomies are contraindicated because of ascites and portal hypertension. So if we try to insert a needle from the outside and have a gastrostomy tube placed through the abdomen into the stomach, there's risk of bleeding because of portal hypertension, and also the ascites will just continuously leak out, so that's contraindicated. And we may need to use parenteral nutrition for patients with liver cirrhosis or liver disease in the same way for the same indications as we would for any patient. So PN is not contraindicated in liver cirrhosis or liver disease, and we shouldn't be withholding this from people because they have liver failure. It's useful to think about the formulas for nutrition support for our individual patients with liver disease. So understandably, high protein, high energy and low volume formulas are probably going to be useful for our patients because they feel full quite quickly and they have high protein requirements. If they're malnourished or losing weight, they'll have high energy requirements. But it's also really important to think about patient preference and tolerance, because if you give them a concentrated SIP feed, like a compact one, and they don't like the taste of it, then they're not going to take it. And so in that case, a less compact one might be better for them. And we know that some of our patients might have reduced tolerance and they might need to have things like Vital 1.5 or Peptamen. So a kind of more of a broken down semi-elemental, elemental or peptide based feed that is potentially higher in medium chain triglycerides as well, if they're struggling for tolerance. And if we have patients who have a lot of malabsorption, these feeds are often the better ones to go for because they are higher in medium chain triglycerides, which don't need the liver to be working and producing bile to absorb and get the calories from the medium chain triglycerides. If we have a patient who has a lot of malabsorption or steatorrhea because of biliary problems, cholestasis, then we may have to choose reduced fat SIP feeds or feeds, so things like Fortijuice or Ensure Plus juice, or the Peptamin and Peptazorb feeds also are low in fat overall, because they may, the more fat that they have, it might make their symptoms worse, and so they may tolerate and absorb the nutrients from these lower fat supplements better. But every patient is different, and even things like the concentrated Fortisip compacts and Ensure compacts are relatively low in fat compared to something like a fried meal, so they may tolerate them absolutely fine. I've also put in here some of the savoury feeds, so things like the soups, Ames savoury, we might think can't be used in our patients with fluid retention and liver disease, but actually if you look at the amount of salt that's in some of the savoury ones, it's exactly the same as what's in the milkshake style feeds, SIP feeds. So do look at that, because if you have a patient who doesn't like sweet things, it might be that there's some savoury options that are no higher in salt than the SIP feeds you'd be giving them anyway. I've included Meritine on here, which some hospitals use, and it's not normally prescribable in the community, but patients can buy it because if made with skimmed milk, then Meritine is virtually fat-free, but still high in protein and giving reasonable amount of calories. And we might just need protein-only top-ups, so things like Renapro shot, Renapro powder, ProSource Plus, for patients who are getting the carbohydrates that they need and the energy that they need, but they have very high protein requirements. And this might be, for example, our patients with obesity and sarcopenia. So I want to quickly talk about liver disease without malnutrition, and this is where you need to still tailor your recommendations for the individual patient. So think about their comorbidities, their risk of malnutrition, their preferences and their desires. If a patient has liver cirrhosis but they're not malnourished, then they need to have a balanced diet. They still need to have frequent and good quality sources of protein. They need to try and be physically active to help with maintaining muscle, and they should still have a cirrhotic eating pattern, but they can do this with lower calorie foods, so healthier snacks, things like low-fat natural yogurt, fruit, whole nuts, rather than biscuits and cake and milkshakes. And there should be a focus on preventing malnutrition, sarcopenia and frailty, because if a patient has cirrhosis, they will be at risk of malnutrition and muscle loss and becoming frail. If a patient has fibrosis or steatosis and they're not malnourished, then remove the cause of liver damage if it's diet related, for example alcohol, or if it's non-alcoholic fatty liver disease, moving to a healthier dietary intake suitable for that. They should be aiming to have a healthy balanced diet and good diabetes control and to be physically active. They don't need to have a cirrhotic eating pattern if they're not malnourished and they don't have liver cirrhosis, so they can have 3 healthy meals a day. And it's also useful to think about liver disease in patients with obesity. So we know patients living with obesity may still be malnourished or at risk of malnutrition. They may have low muscle mass. They may still be experiencing weight loss. And the aim with these patients would still be to reduce the risk of malnutrition, sarcopenia and frailty, but ideally without causing weight gain. And so it's important to look at their stage of liver disease. So they might have liver disease that hasn't progressed to cirrhosis yet. They might have fibrosis or steatosis. And this would just be individualising your care and adapting the diet to support their overall health and their liver health. And if they're malnourished, then also treating that malnutrition in whatever form that malnutrition comes in. So if it's micronutrient malnutrition, protein malnutrition, addressing that, and then really supporting with physical activity or encouraging physical activity, referring on to physical activity services or physiotherapists, because muscle maintenance and improving muscle mass is important for these patients. If a patient has with obesity and they have compensated cirrhosis, then their risk of malnutrition is going to be lower than those with decompensated cirrhosis. But they may be malnourished or losing weight, and they may still need a high energy, high protein intake. And if they have cirrhosis, then they will still need the cirrhotic eating pattern as you would with other patients. If they're not malnourished or if they're not unintentionally losing weight, then they don't need to increase their energy intake. Now, the experienced liver dietitians have found that not all patients with liver cirrhosis and obesity need to have this cirrhotic eating pattern, and that it might be enough to have 3 balanced meals a day plus a healthy, high protein, carbohydrate containing bedtime snack to help preserve muscle, but it might not need to be the full 50 grams of carbohydrate. So if somebody has cirrhosis and they are not malnourished and they're not sarcopenic and they're not losing weight and they're not losing muscle, I would be recommending 3 balanced meals a day and a healthy bedtime snack. If weight loss is desired, so for example, some of our patients need to lose weight to be eligible for a transplant, then it's recommended that we avoid rapid weight loss because that can cause the liver to decompensate. So aiming for ½ kilo to 1 kilo a week of weight loss, still having a high protein diet and a good quality diet with healthy snacks. So things like fruit and whole nuts and low-fat, high-protein yogurts, and that we monitor for decompensation and malnutrition risk and educate patients about this so they know to seek support if they start to lose muscle or weight loss is very rapid and excessive, and if they lose their appetite. So we can support patients to lose weight who have cirrhosis, compensated cirrhosis and obesity, but they need dietitian support and monitoring to check that they're not declining nutritionally, and then the plan would need to change if they were becoming malnourished. And then for anyone with compensated cirrhosis and obesity, physical activity is really important to support muscle maintenance and prevent muscle loss. For patients with decompensated liver disease and obesity, the risk of malnutrition, sarcopenia and frailty is high. And if they are malnourished or losing weight, then they need to be following a high energy, high protein cirrhotic eating pattern in the same way you would with any other patient. If they're not malnourished and they're not unintentionally losing weight, then they're unlikely to need to increase their energy intake, but they will need a high protein intake and a cirrhotic eating pattern. So the advice would be to not eat more overall, but to spread out their eating. So rather than having 3 big meals a day, have 3 small meals and 3 small snacks, and making sure that there's high protein intake with meals and snacks, and that their intake overall is healthy. They're not choosing the biscuits and the cakes and the milkshakes. and still aim for 50 grams of carbohydrate before bedtime. Physical activity is really important to support muscle maintenance and prevent muscle loss. And if a patient does have decompensated liver disease, then weight loss is not usually recommended. But if it was essential, so to get to liver transplant, then they would need close monitoring. So we're going to move on now to talk about the nutritional care for some of the symptoms that patients can experience with liver disease. It's not recommended to restrict protein for patients with hepatic encephalopathy. This is an old way of thinking. So the theory used to be that ammonia is produced from dietary proteins, and that we can improve encephalopathy by restricting dietary proteins. But this is an old theory, and since this, we now have evidence that this does not work. So in a randomised controlled trial, there was no difference in the outcome for encephalopathy for patients on a low protein diet compared to a normal protein diet, but the low protein diet showed more catabolism and muscle loss. And we know that skeletal muscle contributes to ammonia detoxification. So if patients are losing muscle, then the skeletal muscle is going to have less capacity to remove that ammonia, and therefore encephalopathy will likely become worse. In practice, it is still thought that there are a really small number of patients with severe encephalopathy that might be protein intolerant. This isn't evidence-based really, this is kind of clinicians' experience with a really small number of patients. So if a patient had really severe encephalopathy, they were unconscious on the intensive care unit with high ammonia, and all other methods for improving encephalopathy had not worked, such as lactulose and rifaximin and putting them on a filter, so to filtration that the kidneys would normally do to try and remove the ammonia, then we might protein restrict, but it would be to a minimum of 1 gram per kilogram, so not very low, and it would be for a short period of time whilst we monitored their encephalopathy. If there was no improvement in encephalopathy after a short period, so 1 to 2 weeks, then we'd lift the protein restriction. If there was an improvement in their encephalopathy, we would gradually increase their protein intake to whatever they could tolerate. So they might get back up to 1.2 grams of protein per kilogram, for example. And what else can we do to help with encephalopathy in terms of protein? So meeting energy and protein requirements will help to treat and minimise encephalopathy by reducing catabolism, and trying to spread protein intake out throughout the day. So rather than having, most of the protein at evening meal or in one of the meals of the day, trying to have little and often protein throughout the day, and that might help to keep ammonia levels steady. I want to mention branched chain amino acids because ESPEN guidelines do recommend that patients who are protein intolerant, that branched chain amino acids should be used to help facilitate adequate protein intake, and that oral branched chain amino acids should be prescribed in patients with advanced cirrhosis. And there's been a comprehensive Cochrane review that shows that giving patients branched chain amino acids has beneficial effects on encephalopathy. However, in the UK, there are no branched chain amino acid supplements available for us to use with patients. So they do have some formulas in the rest of Europe and in America, but nothing available in the UK. So although this is a recommendation, there is no way of meeting this for patients. The supplement drinks that we have, they do contain branched chain amino acids because it will be a balance or a mix of branched chain amino acids and aromatic amino acids. So the recommendation to have 0.25 grams per kilogram per day might equate to something like 18 grams for a 70 kilogram person or 13 grams for a 50 kilogram person. And it's going to be challenging to meet this from the supplement drinks. So a Fortisip compact protein contains 3 grams of branched chain amino acids. So if someone was having, 4 a day in addition to their food, then they'll be getting 12 grams of branched chain amino acids, but 4 a day would be quite a lot for a 50 kilogram person to be managing. Something like ProSource Plus contains 1 gram per sachet, and Renapro shot contains 1.4 grams per bottle. So they'll be getting some from their supplement drinks, and that's reassuring often for patients who query about this. And they'll obviously be getting some from their diet as well. But there isn't a way really practically of specifically meeting this recommendation as dietitians at the moment for patients in the UK. So coming to fat malabsorption, patients who have steatorrhea because of a lack of bile or because of their liver disease, we would recommend fat to tolerance for these patients. So you would need to do a dietary assessment to look at their intake and see where high fat foods are coming in for that patient. If they're having a lot of fried food, if they're having a lot of creamy sauces on pasta or curries, if they're having full fat dairy, then it would be recommending that they change these higher fat foods to a lower fat alternative that are still nice and high in protein and contain carbohydrate, and then see what happens with their symptoms. And just changing perhaps the fried food might be enough to improve the symptoms for that person. And you would want to do it in a stepwise fashion like that to try and improve the symptoms, rather than outright recommending a low fat diet. Because if you recommend a low fat diet, then they are likely to not get enough energy and to decline nutritionally. Personally, I think fat malabsorption and fat to tolerance really needs to be individualised. So it might be that some people have steatorrhea, but it's not affecting them so much that they need to reduce their fat intake. If somebody is not losing weight because of it, if they feel that their bowel motions are not hugely affecting their quality of life, if it's just a few times a day and they're not, having incontinence or real urgency, then it might be that leaving the fat that they have in their diet is fine for them, for that individual. So I think the key message here is not to go straight in with a low fat diet, to try and look at the fat sources for that patient and reduce the really high fat foods that are coming in, and make sure that you're replacing the energy from those foods with protein and carbohydrate instead. It's recommended that patients with ascites follow a no added salt diet, and the level of no added salt is to restrict to about 5 grams of salt or 80 millimoles of sodium per day. Now, it's not going to be possible for patients to add up their salt intake because their food, most of the salt we have is already in the food that we eat. It's not that it's added salt by the patient, but understanding that 5 grams a day is the level that they're trying to achieve is helpful, because that is not much lower than the 6 grams a day that's recommended for the whole population. So it's not a low salt diet, it's a no added salt diet. And to help patients achieve this, you really need to do an individual assessment and support them individually. So identifying where their salt sources are coming and things that they can change that's not going to compromise their nutritional intake. For example, avoiding adding salt at the table, using lower salt stock cubes, using herbs and garlic and lemon and other flavouring to add flavour. Avoiding high salt foods where there are low salt alternatives. So rather than salted nuts, going for unsalted nuts. avoiding crisps, perhaps having something like a sweet popcorn instead of a crisp, avoiding smoked meat and fish and having a unsmoked alternative, keeping things like bacon and sausages to a treat, maximum once a week rather than every day. And patients should also be advised to avoid salt alternatives like low salt, pan salt and solo, because these can be dangerous in terms of increasing potassium intake, and a lot of them still do contain sodium. So this table on the right is giving some suggestions of foods to have less of. So it's not saying avoid them completely, but foods to have less of, and then lower salt alternatives. So I want to talk you through this study that randomised patients with ascites that was being treated by drains because the medication wasn't effective for it, so refractory ascites, and they randomised them into 3 possible groups. So group A had a no added salt diet, high energy and high protein intake, and a late evening snack that was high in protein and calories, and they also had PN after their paracentesis for 24 hours. So group B was exactly the same as group A but no PN, and group C was just given no added salt dietary advice, so no high calorie, high protein diet, no bedtime snack. And they followed the groups up for 12 months. This was the outcomes that they looked at as part of the study. So groups A and B, which were the nutrition support groups, as well as the no added salt, had similar results across the frequency of the outcomes. So they needed between 1.1 and 1.3 paracentesis sessions on average, compared to just the no added salt group, which needed 2.1 paracentesis sessions on average. The frequency of encephalopathy was about 40 to 45% in the nutrition support groups, compared to 78% in the no added salt group. The frequency of GI bleeds was between 25 and 33% in the nutrition support groups, compared to 53% in the no added salt group. Hepatorenal syndrome was between 15 and 23% in the nutrition support groups, compared to 38% in the no added salt group. And spontaneous bacterial peritonitis, so infection of the ascites, was around 20% in the nutrition support groups, compared to 48% in the no added salt group. So you can see the outcomes were worse for everything for the no added salt group. And these charts are showing the mid-upper arm circumference for the 3 groups, and it's showing that the no added salt only group got significantly more malnourished than the other 2 groups, and the liver disease severity of the no added salt group got significantly worse than the 2 nutrition support groups. And this was survival at 12 months. So you can see that there was a slight difference in survival percentage for the PN nutrition support group compared to the non-PN nutrition support group, but not a huge percentage difference. Whereas the no added salt group only had a worse survival than both nutrition support groups. And it's important to know that there was no difference in participants at baseline, so it did seem to be the intervention that was affecting the outcomes. So the take-home message from this study is that no added salt on its own, without high energy and high protein intake, without meeting requirements, worsens outcomes. So you need to have the high energy, high protein, meeting requirements, as well as the no added salt. So what about your patients with diabetes? So we've talked a little bit about this already, but it's important to monitor blood glucose for patients with liver disease and diabetes, because good blood glucose control is really important important for their long-term outcomes, but also for their nutritional status. However, perfect control might not be possible. So patients with liver cirrhosis have insulin resistance. If they have chronic inflammation and are experiencing infections, then that's going to worsen their insulin resistance. It's also useful to know that HbA1c is not always an accurate measure of glycemic control, so in patients with cirrhosis. So some patients with cirrhosis might have poor glycemic control, and the HbA1c might not reflect how bad that is, and so measuring blood glucose levels is important. Recommend complex carbohydrates, whole grain if possible and if appropriate, and make the carbohydrate snacks between meals small, and make sure that those carbohydrate snacks also include fat and protein, and that will help to minimise the glucose spikes. And the same with the bedtime snack. So you'd still be aiming for 50 grams of carbohydrate, but trying to make it a complex carbohydrate and also containing fat and protein. And collaborate with the diabetes specialist, because if blood sugar control is not good, if there's hypoglycemia, then it's likely that diabetes medication needs to be adjusted to enable a cirrhotic eating pattern. We would not want to be over restricting the intake of people with diabetes and liver cirrhosis, particularly if they are malnourished or decompensated. To talk briefly about nutrition pre-transplant, so good nutrition support is important to optimise patients for major surgery such as transplant, and we'll be aiming to treat malnutrition and prevent or minimise a decline in nutritional status whilst waiting for liver transplant. If someone is malnourished, if possible, we'd want to improve their nutritional status, but being realistic that we're battling against decompensated end-stage liver disease, so this might not be possible. For some patients, controlled weight loss might be required for them to be able to have the surgery, and we've talked about this already, so gradual weight loss and dietetic monitoring, and still achieving that cirrhotic eating pattern that's high in protein if that's what the patient needs. And then nutrition post-liver transplant. So some patients are tube fed after transplant. It's individualised for the patients. They start with oral intake, usually sips of fluids, progress to a light diet and then to a regular diet, and this is done to tolerance as they can tolerate it. In the short term, they need high energy and high protein intake to help meet their elevated requirements, to treat malnutrition and to aid recovery. And then in the long term, there is an increased risk of weight gain, cardiovascular disease. So once nutritional status is recovered or getting close to being recovered, they need to be supported to stop supplement drinks and transition to healthy eating at that stage. Exercise is really important post-transplant, and walking is normally the first thing that patients are able to do and is great for them. And because of being on immune suppression medication, there is a higher risk of foodborne infections, so food poisoning. So we give advice on foods to avoid, things like unpasteurised dairy, soft mould-ripened cheeses, raw or undercooked meat and fish. And some foods interact with their immune suppression medication. So we advise, in Cambridge, we advise that they avoid grapefruit, pomelo, which is an Asian grapefruit, Seville oranges, which are used to make marmalade, and pomegranate.